Hello everyone. Today we will discuss about hydrocephalus. So starting off with its definition, it is nothing but the enlargement of the brain ventricles and or subarachnoid space. So this is nothing but it is the enlargement of brain ventricles or its subarachnoid space. Okay. So how is the CSF being produced and how is this circulated in our brain? So we will see that in a detail. So CSF is being produced by the choroid plexus that is present in the lateral ventricles. So the choroid plexus in the lateral ventricles produce the major amount of the CSF, while the minor amount is produced by the ependymal lining. So minor amount is produced by the ependymal lining and the major amount is produced by choroid plexus in the lateral ventricles. So the daily production. So how much is being produced daily? So the daily production is about 400 to 500 ml per day is being produced. So that is 0.35 ml per minute is being produced in our brain. The total volume that is being circulated inside our brain is around 60 ml in infants and 150 ml in adults. So the production is huge but the volume is less. How is it possible? It is because of the absorption that is being happening in our brain. So the absorption is taken place by the arachnoid villi. So the absorption is by arachnoid villi or its granulations in the in superior sagittal sinus. So the absorption is by arachnoid villi or its granulation in the superior sagittal sinus. How does this absorption takes place? Why does this absorption takes place? This absorption is because of the pressure difference. It is mainly because of the pressure difference between superior sagittal sinus and the subarachnoid space. So it is the pressure difference. Okay. How much is the pressure difference? It is around 5 to 7 millimeter of mercury. This is the pressure difference between superior sagittal sinus and the subarachnoid space, which facilitates this absorption. Okay. So we have seen its production, volume and absorption. Next we will see its circulation. So circulation in its diagrammatic representation I have given it here. It is produced by the choroid plexus in lateral ventricle. So from this lateral ventricle through the foramen of Monro here, through the foramen of Monro, it goes into the third ventricle. From third ventricle through the aqueduct of Sylvius here, it comes to the fourth one. From the fourth ventricle we have two apertures, that is one is median aperture. So you can remember here like median aperture, so it is M, that is foramen of Mejendi and foramen of Lashka, through which it goes into the subarachnoid space. From the subarachnoid here, this is the subarachnoid spaces. From the subarachnoid spaces it enters into this arachnoid villi granulation that is present in the superior sagittal sinus, from where this absorption takes place. So this is the circulation of CSF. So I have given the flow chart here. That is from lateral ventricle it goes into foramen of Monro, then to the third ventricle, next through the aqueduct of Sylvius it goes to the fourth ventricle. From fourth ventricle it goes to the subarachnoid space through two foramens, one is Lashka and another is Mejendi. From there from the subarachnoid space it gets absorbed in the arachnoid villi granulation that is present in the superior sagittal sinus. So this is a simple form of its circulation. Next we will see its pathophysiology of our hydrocephalus. So we will see the pathophysiology. So going on its pathophysiology, this CSF, that is hydrocephalus, nothing but enlargement of this ventricle, brain ventricles or the subarachnoid space because of the over collection of CSF. So the CSF over collection can be one due to CSF overproduction, another one can be due to obstruction. Okay. So what are the causes of CSF overproduction? One is choroid plexus tumor. So choroid plexus tumor can cause CSF overproduction. For example, papilloma, choroid plexus papilloma or choroid plexus carcinoma can cause CSF overproduction. Not only this, not only overproduction, this can also increase the CSF protein. So when the CSF protein is being increased, it can cause blockage. It can cause impairing the absorption. Okay, this protein will impair its absorption, thus resulting in hydrocephalus. Okay, one is due to CSF overproduction. Next we will see the causes for obstruction. This cause of this obstruction can happen at various levels. So I will show with this diagrammatic way, flow chart. So first, for example, when the obstruction is cause of obstruction, when it is in the foramen of Monro here, foramen of Monro and in the third ventricle. So what are the causes of obstruction here? One can be subependymal astrocytoma. First is subependymal astrocytoma. Second cause, craniopharyngioma. Third, it is optic pathway glioma. Fourth, vein of Galen malformation. Fifth is pineal regional tumor. So these are the causes of obstruction where in foramen of Monro and in the third ventricle. Next, the causes of obstruction in aqueduct of Sylvius. Here the cause can be due to congenital cause or can be an acquired cause. So the congenital cause of obstruction can be aqueductal stenosis. So aqueductal stenosis. Second is any intrauterine infection that can cause increase in the CSF protein, and this can also lead to obstruction in the aqueduct of Sylvius, or the infection itself can cause stenosis of aqueduct. Okay. Third can be tuberculosis. Fourth, or it can be due to hemorrhage. So these are the causes of obstruction at the level of aqueduct of Sylvius. Next, what are the causes of obstruction at fourth ventricle? So causes of obstruction at fourth ventricle. First is can be congenital cause. So congenital causes are Dandy-Walker malformation, second is Arnold-Chiari malformation. These two are congenital cause. Next is the acquired cause. Acquired causes of obstruction at fourth ventricle are tumors. Tumors can be medulloblastoma, ependymoma, third is astrocytoma. These can cause obstruction at fourth ventricle. Next, at the subarachnoid space. Next we will see at the subarachnoid space. So cause of obstruction at subarachnoid space can be tentorial hiatus. A tentorial hiatus is obstructed by extensive basal tuberculous meningitis exudate. Here a tentorial hiatus. Okay, there can be an obstruction by basal tuberculous meningitis exudate. Okay, so these are the causes of obstruction that can lead to hydrocephalus. Okay, next we will see its clinical signs and symptoms, or its clinical presentation. So next, going on to its Clinical presentation. In infants, can present with rapid increase in head circumference. So there will be a rapid increase in head circumference. Second, there will be a tense bulging fontanelle. There will be a tense bulging fontanelle. Third, there can be sun setting sign in the in the eyes. The child can have vomiting. It can present with episodes of apnea. So these are the symptoms. Plus this is the symptoms when the child develop a acute or a immediate hydrocephalus. These can be the immediate symptoms. Or else when the child have a chronic hydrocephalus, the child can develop drowsiness, or slowly developing hydrocephalus, the child can have drowsiness, irritability, and upward gaze palsy. The child will have this McEwen sign. McEwen sign is nothing but a crackpot sound. That is McEwen's sign. This McEwen sign is present when the child is having hydrocephalus. This can be a 1 mark question also. That is the cracked pot sound. Next, the clinical presentation in children. The child can present with headache, vomiting. That will be a projectile vomiting. There will be behavioral problems. And visual impairment. On examination, you can find the child to have a 6th nerve palsy, papilledema, optic nerve atrophy, gait disturbance, and seizures. Okay, so these are the presentation in a child with hydrocephalus. So when there is an increasing intracranial tension, there will be you have to do a rapid treatment with at least simple ventricular drainage through this anterior fontanelle in infants. Okay, so what is the management you do and what are its investigations? So going on to its investigation. First is USG, ultrasound of the cranium in infants, because they have this fontanelle. This anterior fontanelle acts as a window, so you can view through this USG. So this is for infants. It is to look for the progression in asymptomatic children. It is to look for the progression and the size of the ventricles in asymptomatic children or in minimally symptomatic children. First is USG, second is CT brain. This is the imaging of choice. So imaging of choice in a child with hydrocephalus is CT brain. Before you perform any definitive procedure or surgery, you have to do a CT brain. In CT brain, what all you can find? You can find the size of the ventricles. You can find whether the subarachnoid space is enlarged or not, or whether there is obstruction like tumor or any cyst that is causing obstruction, or whether there is a features of infections. In what is this called, tuberculous meningitis, you can have basal meningeal exudates will be present, so you can find the features of any infection are there or not. You can find any congenital malformation in the CT. Next, this is the imaging of choice, CT. Next, the MRI brain. MRI brain is mainly done to pick up for the cause of aqueductal stenosis. So MRI brain is mainly done to pick up the cause for aqueductal stenosis. So this aqueductal stenosis that congenital, this is mainly congenital. It can be like a forking one or a septum can be present. This can be a present like the stenosis can present like forking or like a septum. So this can be found in this MRI brain, but this is not a definitive imaging of choice. CT is your imaging of choice in a child with hydrocephalus. Next we'll see the treatment. In treatment part you have medical management and surgical management. In medical management you give the child with when there is an increase in intracranial pressure, you treat the child with IV mannitol at the dose of 0.25 to 0.5 grams per kg per dose over 10 to 20 minutes, or you can give 3% NaCl at 5 ml per kg can be treated. Okay. Next is the surgical management. In surgical management you have first one is external ventricular drainage. External ventricular drainage, that is EVD. This is an emergency procedure. It can be done even in the bedside also. So external ventricular drainage, it is an emergency procedure. Sorry. This can be done in the bedside or in the OT. This is done in an emergency way to relieve the acute hydrocephalus. It is done to relieve this acute hydrocephalus. In case of so when you do this external, I'm not going into a detailed procedure of this EVD. So when you do this EVD, suppose if you find the child to have a hemorrhage or this infection. So when a child gets this acute hydrocephalus due to hemorrhage or infection, you have to do a serial cell count, that is CSF. So you have to do a serial CSF cell count, CSF sugar, glucose, protein and culture. It should be done in a, you have to monitor this everything. So once this CSF protein is, so when you find the CSF protein to be less than 0.5 gram per liter on your serial investigation, this is the time for trial closure of drainage. So when once the child gets a CSF protein of less than 0.5 gram per liter, you can do a trial closure of this EVD to check if there is any raised ICP or not. So trial closure of drainage to check for a raised ICP. So next, when in a case of an infection, when the child have a consecutive 3, when the 3 CSF consecutive cultures are negative in case of infection, then you can plan for a permanent drainage or a permanent shunt. Because when you perform a shunt procedure, the child should not have any infection. If there is infection, next, because there can, so when there is an infection, there will be an increased amount of protein. So when there is an increased amount of protein, the child will have increase in exudate. When you do a shunt procedure, this exudate can block the shunt tubings. So that will be a mere waste of procedure. So that time you have to do a external ventricular drainage. When the culture is being negative or when this infection is being treated, then you go for this permanent shunt. Okay. Next we'll talk about the shunt systems. So the most common shunt that is being done is ventriculoperitoneal shunt. This is 90% of the cases we go for this ventriculoperitoneal shunt. This ventriculoperitoneal shunt system, this consists of a ventricular catheter. I'll write it here. It consists of ventricular catheter. Next, a valve mechanism. Next is the peritoneal catheter. So these are the the things that this VP shunt contains. In valve mechanism, we have 2 types. One is pressure regulated, another one is flow regulated. In pressure regulated, you have, again, it is classified into two. One is differential pressure, another one is adjustable pressure. This adjustable pressure valve mechanism, it is very expensive and we are not using it. We use this differential pressure. In differential pressure also you have low, medium and high pressure. In most of the scenarios we use this medium differential pressure regulated valves is most commonly being used. Okay. Next, in coming to this flow regulated one, this is flow regulated one. It maintains a constant flow of this CSF from the ventricles to the peritoneum. So it maintains a constant flow of CSF irrespective of the pressure that is being between ventricles and the peritoneum. So this is mostly used in infants with the large ventricles, which one, this flow regulated one. Okay, so we have seen about the first one, that is ventriculoperitoneal shunt. Next we will have ventriculoatrial shunt. So this is between the ventricles and the right atrium, mainly the right atrium. This is done through, the shunt is being inserted through common facial vein or this internal jugular vein. The shunt is being inserted through common facial vein or through this internal jugular vein. So they are being placed in the right atrium. We are using the X-ray guidance. So this ventriculoatrial shunt, when it is being used, this is being used only when the peritoneum is not in a condition to be placing the ventricles, placing this shunt, like when the peritoneum has any infection or there are multiple adhesions in the abdomen. So that time you can use this ventriculoatrial shunt. Next, third type of shunt is, it is ventriculopleural shunt. This pleural shunt is done only in the children more than 7 years of age. So this is done in children more than 7 years of age. Why? Because there is an increased risk of fluid overload. So it is being done more than 7 years of age. So this when you find the child to have a hydrocephalus in utero while doing an USG, this fetal therapy can be done. In this fetal therapy, there is the shunting is between ventricles and the amniotic cavity. So this intrauterine surgery for hydrocephalus is done. That is shunting between the ventricles to amniotic cavity. This is done before 24 weeks of, this is 24 because 24 weeks of gestational age. Okay, next, this is about the treatment. So we have to see in the medical management and its surgical management. Next we will go on to its complications. This complication is a separate 7-mark question for you in your examination. So I will just tell you the hint, like what are the points you have to write in complications. So you have immediate complications and late complications. So in immediate complications, you can write infection, shunt infection. Second, you can go for malfunction of this shunt system. Malfunction can be due to increase in there can be raised ICP because of wrong placement of the shunt. Third, you can go for bowel perforation. Fourth can be hemiparesis, when you disturb the cortex, motor cortex. The child can have this hemiparesis. There can be intracranial hemorrhage. The child can get wound dehiscence. There will be CSF leak. There can be peritubal CSF leak. the child can develop seizure also. Okay, so this can be immediate complication. In late one, the child can develop abscess. It can go for tube dysfunction or disconnection. The child can develop blindness. Okay, the child can develop blindness due to posterior cerebral artery infarct. Next, when you place the shunt, when the child is having some tumors, so when the tumor is in a grade 4 stage, or when it is in a very active stage, that can lead to seeding of the tumor, that is can be a metastasis, or the tip can get migrated, so there will be a tip migration. So these are the complications of the hydrocephalus procedure. Okay, the shunt procedure. So you have to rate each at least one point for each of this topic to cover your 7-mark question. Okay, so this is about the hydrocephalus. I've told you in a short. Thank you. In next video we'll have a newborn or this neurology class. Okay, anyway, thank you. Have a nice day. Please like, share and subscribe our YouTube channel. Let's all learn pediatric together. Thank you.